Okay, let's dive into this. When someone loses a tooth, you kind of assume the bone underneath just sits there,
Yeah.
right? But that's not really what happens.
No, not at all. It's actually a pretty dramatic process. The bone that was specifically there to hold the tooth starts to basically melt away. It
Yep. It
resorbs.
actively disappears, yeah.
Yeah.
And we're talking today about when this goes really far, advanced alveolar ridge resorption. That's the jawbone ridge that supports teeth or, dentures.
Exactly. When it collapses severely, you end up with these really challenging situations for making any kind of replacement work. We often call them flat or flabby ridges. It's a major structural loss.
So our mission today is to dig into the advanced source material covering this. We want to understand what causes these flat and flabby ridges, the biology, the mechanics.
And crucially, the specialized techniques needed to manage them. Some of these solutions are, well, pretty counterintuitive. We're tracing the culprits, both biological and mechanical, that can really ruin a denture success.
And it's rarely simple, is it? The sources suggest it's often a mix of things aging, how someone looks after things, maybe even small mistakes in how a denture was made.
Absolutely, they all intersect. So let's start with the flat ridge. This is mainly a structural bone loss problem.
Okay, the flat ridge. So the bone has dissolved away almost completely. It happens naturally over time, but sometimes it goes way faster. Why?
Well, the anatomy plays a big part. The sources point to the type of bone. The inner spongy cancellous bone resorbs much, much faster than the dense outer cortical bone.
Okay, so if the ridge was already kind of thin or narrow?
It's predisposed to flatten out quicker.
Yeah.
Yeah. Then you add the biological accelerators, things like getting older, hormonal changes, especially postmenopause in women, and nutritional issues.
Like low vitamin C or calcium.
Exactly. And systemic problems too, like uncontrolled diabetes or maybe radiation therapy in the area. They all ramp up that natural bone loss rate.
But, the sources really hammer home the iatrogenic factors, stuff caused by treatment, basically. Poorly made dentures seem to be a huge accelerant.
Oh, absolutely. It's like repeated trauma, but on a small scale. Imagine wearing an old, loose denture, maybe one where the bite isn't quite right.
What do you mean bite isn't quite right?
Well, think about how your teeth meet. If the denture forces your jaw into an unnatural position every time you bite, or if it's built too tall, what we call high vertical dimension or VDO,
Okay.
that creates leverage and puts excessive damaging force onto the ridge. Or if the position where your jaw joint is comfortable centric relation, or CR, doesn't match where the denture teeth meet centric occlusion, CO.
So every bite is a little trauma.
Precisely. That constant stress basically tells the bone it's under attack, and it speeds up resorption massively. Decades of loss can happen in just a few years.
And the material of the teeth matters too, right? The sources mention porcelain versus acrylic.
Yeah, big time. Porcelain teeth, or very detailed anatomic teeth, transmit forces really directly. On a compromised ridge, that's bad news.
Yeah.
Acrylic teeth are softer, they absorb some shock.
So most bone loss is right after extraction, but it keeps going, like 0.5 to 1% a year.
That's the background rate, yeah. And it adds up until the ridge is flat. And the big problem then is stability. You lose the borders, the height. You can't get that suction seal to hold a denture in place.
And it's not just the bone height disappearing. Things that were buried deep suddenly become exposed near the surface, don't they?
Exactly. Sensitive spots, like the genial tubercles on the inside of the lower jaw,
Yeah.
or the mylohyoid ridge where muscles attach, they start to stick out.
Ouch.
But the really serious one is the mental foramen, where the nerve for the lower lip and chin comes out. As the ridge flattens, that hole moves closer and closer to the surface.
Which means the denture presses right on the nerve.
Yeah, causing terrible pain for the patient. And in the worst cases, especially on the lower jaw, you can actually get dehiscence of the mandibular canal. The main nerve bundle itself becomes exposed. It's pretty severe.
Wow. Okay, so if the bone foundation is basically gone, what are the options? Do you try to rebuild it surgically or just work around it?
Well, the sources lay out a kind of decision tree. Surgically, you've got a few routes. One is vestibuloplasty.
What's that involve?
It's basically deepening the space, the sulcus, next to the ridge. You surgically move the muscle attachments lower down, effectively making the usable ridge height taller. Then it's held in place with a stent while it heals.
Okay, and rebuilding the bone itself.
That's ridge augmentation. Adding height and width using bone grails may be taken from the patient's hip or rib. That's autogenous.
Right.
Or using donor bone, animal sources, or synthetic materials like hydroxyapatite.
What about that other one mentioned, distraction osteogenesis? Sounds intense.
It is pretty intense. It's more for gaining height. You make a careful cut in the remaining bone, attach a device, and then slowly, day by day, turn a screw to separate the bone segments.
And new bone grows in the gap.
That's the idea. It can create significant vertical bone, which is great. But the sources warn it's very technique sensitive, high risk of infection, things going wrong, high failure rate if not done perfectly.
So given those risks, are people moving away from these big surgeries unless it's absolutely necessary?
Generally, yes. The modern approach highlighted in the material, kind of the gold standard for these really flat ridges, is often overdentures supported by implants.
Oh, so implants provide the stability the bone can't.
Exactly. Even just 2 or 4 strategically placed implants, often with simple attachments like balls or bars, can give the denture the retention and support it desperately needs. It bypasses the limitations of the flat ridge itself.
Okay, so if surgery isn't the route, or maybe alongside implants, the non-surgical approach is all about the denture itself, particularly the impression.
Precision becomes absolutely critical. The goal of the impression is to capture the maximum possible area for support without pushing on muscles when they move.
And you need perfect contact, right? But also relief over those sensitive spots.
Precisely, like the genial tubercles or the mental nerve area, you can't press on those, so you need special impression techniques. Selective pressure is one where you relieve the tray over sensitive areas but put pressure elsewhere.
Or the dynamic technique.
Yeah, that one aims to capture the shape of the tissues while the muscles around them are working, trying to find that neutral zone between the tongue and cheeks.
And you still need to control those forces, right? Keeping
yeah.
VDO low.
Absolutely key. Minimize that lever arm. The vertical dimension of occlusion should be kept pretty minimal, usually just 2 to 4 millimeters more open than the jaw's natural rest position, the VDR, and stick with acrylic teeth for shock absorption.
Okay, let's switch gears now. From the flat ridge, the bone problem, to the flabby ridge. This sounds more like a soft tissue issue.
It is, fundamentally. It's less about the bone vanishing and more about the gum tissue becoming, well, flabby and mobile. It's a tissue response.
Is it just swelling?
It can be. We need to distinguish hypertrophy, which is just an increase in the size of the existing cells, like swelling, often reversible, from hyperplasia.
Okay.
An increase in the number of cells. That tends to be irreversible tissue growth. Flabby ridge is usually hyperplasia caused by this chronic sort of pressure cooker effect.
Pressure cooker, what's causing the pressure?
Usually, it's excessive focused force and trauma from a denture. Maybe someone only chews on their front teeth or wears their dentures constantly without giving the tissues a break.
And those prosthetic issues again. High VDO, bad bite alignment.
Exactly. If the denture doesn't fit right or the bite forces are concentrated in one area, the tissue underneath reacts to that chronic irritation by proliferating.
The lecture material mentioned a classic scenario, Kelly syndrome or combination syndrome.
Yes, that's the textbook example. You have a full upper denture opposing only the lower front natural teeth, maybe with a partial denture replacing the back ones.
So the lower front teeth hammer against the front part of the upper denture.
Relentlessly. And what happens? You get predictable bone loss in the upper front ridge, and the gum tissue there becomes hyperplastic and flabby. The forces are just unbalanced and too high in that one spot.
And this kind of chronic irritation can cause other specific tissue problems too.
Definitely. You might see papillary hyperplasia on the palate. Looks like a bunch of small pink bumps, often linked to poor hygiene under the denture. Or epulus fissuratum. That's that roll, or sometimes double roll, of extra tissue that forms in the sulcus, right where an overextended denture border is constantly digging in.
So how do you manage a flabby ridge? Is it surgery first?
Usually not. The absolute first step, emphasized in the sources, is non-surgical. Remove the cause, adjust the bite, shorten any border that's too long.
And tell the patient they have to take the denture out, right?
Critically important, at least 8 hours a day, usually overnight, to let the tissues rest and recover.
I saw a note about massaging the tissue and using saline rinses. Why saline?
The sources suggest saline can help reduce edema, kind of gently shrink the puffy tissues through osmosis, calming down the inflammation. It's part of letting the biology recover before you make a new denture.
And if the bite force distribution is the issue, there's something called tissue conditioning material.
Yes, this stuff is crucial. It's a very soft, temporary lining material you put inside the existing denture. It cushions the flabby tissue and helps spread the biting forces more evenly.
But it's not a permanent soft liner.
No, definitely not. That's a key difference. Tissue conditioner works because it flows and adapts, but the plasticizers that make it soft, leach out fairly quickly. It gets hard within, say, a week.
So you have to change it often.
Yeah, every 3 to 5 days usually, until the tissue looks healthier. It's a treatment phase, not a final solution.
And because that tissue is so soft and mobile, taking an impression is tricky. You can't squash it.
Exactly. If you use a standard thick impression material, you'll just displace the flabby tissue. The impression and the resulting denture will look like the tissue is firm, but it's not. The denture won't fit the resting tissue.
So you need something really runny.
Low viscosity is the rule. For the first primary impression, something like alginate that flows easily without pressure.
And for the final, precise impression, there was a special technique mentioned, sectional.
The sectional or two-part technique, this is pretty clever. You make a custom tray, but you actually cut out the section over the flabby area, leaving a window. Then you take the main impression of the firm areas first. After that sets, you mix up a very, very runny material, like plaster of Paris, and carefully inject it through the window to record the flabby tissue in its completely resting, uncompressed state.
Wow, like taking a picture of a water balloon without squishing it.
Kind of, yeah. It's the only way to get an accurate base for a denture that needs to sit passively on that unstable tissue. Prosthetically, you'd then likely use flat, non-anatomic teeth and try to set them in that neutral zone again.
Okay, broadening out a bit. Success isn't just the main ridge. The sources highlight some other, maybe more subtle anatomical things that can cause big problems.
Absolutely. Like an abnormal frenum, those little muscle tethers in the lip or cheek. If one is really prominent, you can't just cut a huge notch in the denture border for it because you'll lose the peripheral seal right there.
So that might need minor surgery to reposition the frenum.
Often, yes. Or take a tight lip. You wouldn't think it, but the muscles around the corner of the mouth, the modiolus complex, can really destabilize a lower denture if the lip is tight. It tends to pull the denture up and back, especially around the premolars. The fix is often counterintuitive. Extend the denture base further back onto the retromolar pads for anchorage, keep the teeth narrow, and maybe make the upper canines a bit prominent to shield the lower denture.
Amazing. So muscle pull way over there affects the whole design.
Yeah.
What about palate shape? A really deep V-shaped palate.
Yeah, that's a tricky one for acrylic dentures. As the acrylic cures, it shrinks slightly. In a deep V palate, it tends to pull away from the deepest part, breaking the seal.
So what's the fix?
Often, using a metal denture base is better because metal shrinks much less. And again, a really accurate functional impression technique is vital to capture that seal perfectly.
And Tori, those bony bumps some people have on the palate or inner jaw.
Tories are trouble because they're hard and unyielding. If a denture rests on one, it creates a pivot point. When the person bites on the other side, the denture rocks.
So you need relief over them in the denture.
Definitely need relief. Or if they're very large and interfere with the seal or speech, they might need surgical smoothing.
Okay, one more. A large tongue. How does that impact things?
A large active tongue can easily destabilize, especially a lower denture. Solutions involve making the teeth narrower side to side, buccolingually, maybe only using one molar per side instead of two, and sometimes setting the front teeth slightly forward to give the tongue more room.
Let's circle back quickly to those soft tissue problems caused by denture trauma, because the management approach seems really key. Epulus fissuratum, that fold of tissue from an overextended border. Why the caution against immediate surgery?
Because surgery leaves a scar. And scar tissue in the sulcus doesn't function like normal flexible tissue. It compromises your ability to get a good peripheral seal and proper extension for the next denture.
So the advice is?
First things first. Shorten the denture border that's causing the irritation. Give the tissue weeks, maybe months, to rest and heal. Often the epulus shrinks dramatically, sometimes disappears. If surgery is still needed, it's much smaller, preserving more healthy tissue.
That remove the cause first idea seems powerful. What about denture stomatitis, that red inflamed palate, often linked with candida yeast? Is it just an infection?
The sources are clear. It's rarely just an infection. Candida is often present. It's an opportunist. But the primary cause is usually trauma from an ill-fitting denture, maybe combined with poor hygiene.
So just giving antifungal medicine won't fix it long term.
Exactly. It might clear the yeast temporarily, but if the trauma continues, the inflammation and redness will just come back. You have to address the denture fit first, usually with that tissue conditioning program to allow healing. Then, if needed, antifungals can be effective.
So pulling this all together, what's the big takeaway? Managing these advanced cases, the really flat or flabby ridges, hinges entirely on getting the diagnosis right. Is it bone loss or is it a tissue reaction?
Precisely. You have to know if you're fighting a mechanical structural problem, the flat ridge, or a tissue pressure problem, the flabby ridge, because the solutions, whether surgical or prosthetic, are very different and highly specialized, sometimes surprisingly minimal.
Yeah, it seems the difference between success and failure can be tiny details. A few millimeters on a denture flange, choosing acrylic over porcelain, using that sectional impression technique.
Absolutely. Those details become critical when the foundation is compromised.
And it's fascinating how much healing can happen just by fixing the mechanics, like shortening that flange for the epauleus or resting the tissue with conditioner. It really makes you think, doesn't it?
It does.
So here's a final thought for you, our listeners, to consider. When we're dealing with tissue problems clearly caused by some external mechanical irritation, like these denture issues, how often might the simplest, least invasive fix, just removing that irritant, actually be the most beneficial long-term strategy for preserving function compared to jumping straight to surgery?